Good morning, everyone. In the LifeTech supported teaching sessions, I am just presenting PDA closure. I am Dr. Edwin Francis from Pediatric Cardiology, Lisie Heart Institute, Cochin. PDA device closure is one of the routinely done intervention by any pediatric cardiologist or even adult cardiologist, and one of the very basic interventions done. It's supposedly a very straightforward intervention, which nothing should go on routinely. But if you are not careful, and when you are doing more difficult ones, you need to be more careful, and things can go wrong. I'll just illustrate a case in which when things didn't go as usual, and then this is learning for many of the junior consultants and fellows who are in training. So just to revise, this is a routine PDA cartoon of a PDA in which a PDA device has been seen as a black cartoon. Nowadays, it's more often PDA devices done and coils are come out of style because it's a bit more difficult and you need more experience and more judgment, while a PDA device is more easily done. So probably it is always better to try for a PDA device unless you are very good in interventions. And one more negative point with the coil is a few coils are not MRI compatible, while almost all devices available routinely are compatible with MRI. So you don't need to worry later when you do a PDA or MRI for the baby or a patient later on. So this is an ideal position, but what could go wrong? When you end up undersizing a PDA, you may embolize the device and it may more likely to go into the pulmonary artery. Or if you are oversizing it and it might protrude and cause obstruction to the more often to the left pulmonary artery, like as it's shown now, or if it is not properly positioned, it can cause aortic obstruction. These problems are more often seen in infants and small kids when you undertake a PDA device closure in a large PDA where things can go wrong. So you need to be very careful. So I'll just go ahead with my case today. It's a 5-month-old, 5-kilo kid with a large PDA, and somebody has done a PDA closure. A week later, the patient remained in the hospital and was symptomatic, and the patient was referred to my center since things were not looking good. So what is it? Here is a tachypneic child who had underwent a PDA device closure. He is quite tachypneic. There is chest retractions of 60 to 70 per minute of respiratory rate. On clinical examination, the pulse rate is around 160. The lower limb pulses are weak. And on chest examination, there is bronchial breath sounds on the left side. The baby was admitted. Lab investigations done showed total counts were elevated at 24,000, a CRP of 120, and ESR elevated at 75 millimeters per first hour. So we could see, actually they came with an X-ray. So actually didn't do an X-ray when it came to my hospital. So this was just for instead of X-ray, I'm showing that one first fluoro picture in which you can see a large device in situ. You don't see it is actually nearly an AP view only, but the whole mediastinum is shifted to the left side and there is cardiomegaly. So what are you going to do? Just an X-ray was, X-ray as I've shown for that. Now an echo shows a large device sitting, occluding the main, you can see in the cartoon, in the echo still picture here, the device is showing an arrow, which is almost completely occluding the left pulmonary artery in the parasternal short axis view. And in the suprasternal view, you can see a turbulence at the aortic arch with decreased flow towards into the lower limb. So here is a case in which where there is a large device in situ which has caused LP obstruction with a left lung collapse, and there is an aortic obstruction with weak lower limb pulses. And as time gone, patient has gone into sepsis also. The final diagnosis: 5-month-old, post PDA device closure, total left pulmonary artery occlusion, aortic arch obstruction, and sepsis. So what are you going to do here? Like, what are the challenges here? The time has gone since almost a week since the initial procedure has been done. There is septic, patient is sick, there is most likely to be thrombus in the LPA as an acute left pulmonary artery obstruction. There is thrombus in LPA. There is aortic obstruction. And then the vascular access, I don't know whether it's available. The first procedure they have tried to put in a big sheath, they said 7 French sheath from the right pulmonary artery and then vein and then taken an artery also. And then there is a collapsed lung with a distorted anatomy. And what you're supposed to do is to retrieve a 12 mm device through a small venous channel. And if successfully retrieved, how do you retackle the PDA? So the question is whether you go for a surgical correction or a transcatheter. Whenever you get into an infected device, it's almost always the first principle is to get the device out first. Then we need to think about the rest of the things. But in this case, to surgically remove a device which is obstructing the LPA and the aorta, you may require a cardiopulmonary bypass, which may be needed. His left lung is gone, so you are likely to have a long postoperative ventilatory course. So it's going to be a tricky job with surgery, but once you retrieved it, ligation is going to be the most safer. But while you think about transcatheter solution, it's going to be tricky to relieve. I've never taken a device out more than nearly a week old and is septic. And even if you're able to retrieve it, again, you may have to send for the surgery later. But even then, I thought that would be a better option since you can remove it and then go send for a surgical ligation so that you can avoid a cardiopulmonary bypass in a sick kid who is septic and infected. So this is a first attempt I do on a transcatheter closure. I take up this was a 12 mm vascular plug, which I thought it was supposedly go through a 6 French sheath, but I take a 7 French sheath. Yes, right femoral venous access could not be got as femoral access. So I went through a left femoral venous access, and then using a 10 mm snare, I catch hold of the screw of the vascular plug, and then I try to retrieve it. It comes reasonably well without much trouble. And then the last video shows it's almost completely in. Before I took him to the cath lab, few things I just forgot to explain, which I've done as the moment the patient came in, I have sent a blood culture. I started on broad spectrum antibiotics. I even started him on a heparin anticoagulation, IV heparin, so that whatever thrombus should not propagate further. So that was almost given for 24 hours before I took the patient to the cath lab. So on a antibiotic coverage, I attempt this, and almost 3/4 or nearly 90% of the device is into my 7 French sheath. So, but then you can see this fixed frame. The distal part of the device was not coming into the vascular plug, was not coming in. I reasonably well pulled it, but still it was not fully coming in. Probably a lot of fibrous tissue and some clot, organized clot, and has been pulled into the tip of the device. So I pull it all en masse, and then things are fine. So the next question is, what is next? Device has been successfully retrieved. The aortic obstruction and left pulmonary obstruction is relieved. But now I have a small kit, tachypnic, septic with a large PDA, more than 2:1 shunt, with the LPA thrombus and a left lung collapse with the sepsis and a vascular access, which is again a left access probably lost while pulling out the last tip of the device. As blood cultures were improved, didn't grow anything. Counts were improving. CRP coming down, and I continued heparin infusion and chest physiotherapy. Was a good respiratory physiotherapist who helped us on 48 hours. He did a very good job. And 2 to 3 days later, I repeated an X-ray. This was an X-ray immediately after the device removal, in which the left lung is completely collapsed and the mediastinum shifted to the left. And then this was around 2 days, 48 hours later, left lung is partly opened up. So as 3 days later, I didn't want to sit on him too long, as blood CRP has come down to 15. So I thought I will give it a try. Blood cultures are negative. There is no evidence of septicemia per se, except for the left lung, which is damaged. I thought I will try to do an angiogram and see whether I can consider for a transcatheter closure, or probably if or I thought if it doesn't fail, I will send him for a surgical closure. So then came the problem of the access. The left was completely occluded on the after my retrieval. The first one also was quite stenotic, since the first attempted PDA closure was to the right side, and the left side was almost completely occluded. So with my carefully we try to get an access from the upper end of the right femoral vein and managed to get an access, and then we did a angiogram of the an aortic angio, which showed a large tubular PDA in a 5-month-old child, in which the opening was nearly 4 to around 5 millimeters was the size of the PDA at the pulmonary artery end. So you can see a still frame, which is not so good, but it's a severe PAH, a long tubular PDA. So what is the option here? Definitely, if you are not a very expert, it's better always to send him for a surgical ligation. A routine regular PDA device, it may not be the suitable for this case, because it may not, the long tubular one may not be well accommodating the shape of a regular PDA device. So a vascular plug will be a better option in these case scenarios. So I took a 8 mm vascular plug. The 12 mm vascular plug had caused significant problem. So with obstruction, so I had no choice. I can't take anything. A 10 was only 2 millimeters smaller, which would obviously again cause obstruction to the neighboring structures. So I had only choice of 8 mm. I cannot put anything smaller than that. Even an 8 mm vascular plug, which I initially attempted, it just came through like easily. So what I did is I tried with a guidance. I put in a guide, 5 French guide into the arterial side, and then was checking with my colleague, was helping me with the small injections while I deployed it predominantly into the aorta. So it was partly occluding the aorta, but then I just kept it that way, and then I could see the position, know that it is one discus very well into the aorta, one discus, middle discus partly into the PDA, and the third discus definitely within the PDA. So once I got this position, because once or twice the whole device was coming in, so then keeping the guidance from the aortic angio, I subtle pull on the PDA, the vascular plug. I could get one disc, or the one disc alone, come into the pulmonary artery, while the middle disc and the distal disc remained within the PDA, so that there was some stability. I waited for a few minutes, and then angiogram done showed a complete occlusion of the PDA, absolutely no concern with the aorta, and an echocardiogram showed the LPA was well preserved and there is no problem. So the vascular plug is unlike a regular PDA device, it's more softer device with no material within, no fabric within. So it is very soft. And then if you try to pull it like an ADO1, it's going to easily come out. So you have to be very gentle with this device. And check angios from the aorta might give you good guidance in positioning of the device. So this is the final position of the device. This is a P angio to make sure that the left side is clean, the pulmonary artery side is clean. So the first angio shows the aorta is very clean, and the pulmonary artery injection shows even now a definitely increased flow into the right lung. And then because of the previous clots here, you can see still there is some peripheral filling defects because of the clots, which was already there previously. But the LP origin was absolutely clean. So to conclude, the transcatheter interventions in infants can be quite challenging. Even a routine PDA device should be respected closure in a patient when you have a large PDA in a small baby. And then it is always advisable to do such procedures in a center when you have more expertise and you have colleagues which can help you, and then the radical facilities to tackle the complications.